Thank you, and we are all here because we are curious about intersex, and not because intersex is a curiosity. It's my pleasure and honor to introduce Eric Vilain, who is an MD, PhD. He's a professor of human genetics, pediatrics, and neurology in the David Geffen School of Medicine at UCLA. He earned his MD from the Paris Children's Hospital Necker, his PhD from the Pasteur Institute in Paris, France, and then he completed a postdoctoral fellowship in medical genetics at the University of California, Los Angeles. He is the chief of medical genetics, the co-director of the Clinical Genomics Center, and the director of the Center for Gender-Based Biology at UCLA. He's the upcoming director of the Center for Genetic Medicine Research at Children's National Medical Center in Washington, D.C., and the chair of the Department of Genetics and Precision Medicine at George Washington University. His lab explores the genetics of sexual development, focusing on the molecular mechanisms of gonad development, as well as on the genetic determinants of brain sexual differentiation, including sexual orientation and gender identity. He has identified a large number of mutations in sex-determining genes and developed animal models with atypical sexual development. He has received numerous awards, notably from the National Institute of Health, the March of Dimes, the Doris Duke Charitable Foundation, and the Society for Pediatric Research. He has published extensively in the field of sexual development. He's a fellow of the American College of Medical Genetics, a member of International Olympic Committee on Hyperandrogenism in athletes, and a member of the board of scientific counselors from the National Institute of Child Health and Human Development. And last but not least, Eric, you forgot to write that you are the director of Epidapo. And you were a great support in organizing this conference. Thank you.
Thank you very much, and welcome. Good afternoon, everyone. And as Ellen was saying, we can do better, and it's true. And as a clinician, it always pains me when there is a lot of misunderstandings between the medical community and the patient's community, and it's the dialogues are difficult. And I'll talk a little bit about this and try to see how we can do better, as you just said. The more I've been thinking about this field, the more I realize things are more and more uncertain. And when I started about 30 years ago as a medical student, at the French Hospital for Children, Necker, it was a very simple field. The team, my first rotation was on in a service that dealt with children with intersex, and every month there was a meeting, and there were decisions made about gender assignment and surgical assignment, and it was very easy. People, I was listening as a young medical student, and people were like, "Oh, okay. Male, female, let's wait a little bit," mostly not. And there was this sort of assurance from the medical group. And I rapidly recognized that it was based on pretty much not much. There was absolutely nothing known about outcome, about physiopathology, about anything. And I decided to embark in understanding it better. And every time I think I understand it better, I just don't. So I thought about it as really a world of uncertainties. Vanessa mentioned my role as an advisor to the International Olympic Committee. And this is only to show you that the questions of intersex go way beyond academia, way beyond clinic. They really impact as of course many people know who live with intersex, but it impacts other parts of society, and sports is a good example of it. And I'm sure some of you are familiar with Caster Semenya, who is this South African athlete who won the 800 meter in 2009 in Berlin World Championship, and was very rapidly accused by the media in pretty strong and derogatory terms to not be really a woman. And she says like she's a hermaphrodite. And she's depicted in this article in this very masculine pose, sort of to make the point that this was just unfair. And of course, you can see how images in the political world count. This is You, which is the equivalent of People magazine in South Africa, showing a week later Caster Semenya sort of wearing all the attributes of typical femininity. She's made up, her hair is long, she has jewelry on, her nails are painted, and she wears a dress. And so, and it's of course the same woman. So it's really interesting how sort of images of people with any kind of variation, and that's just true for everything, including sex, can be politicized. Why do we care about intersex? Well, I come from two perspectives. One is the biological significance, because it helps us understand sex differences in physiology and medicine at the large level. And it has a lot of implications in understanding a number of questions regarding biology of reproduction, questions of infertility. Many patients with intersex are not fertile, and cancer. There is an increased susceptibility to cancer in a number of intersex conditions, not all. And it also has, of course, a human significance. By just caring for chronic condition involving sexual organs, it has a lot of societal implications, which is the topic of this symposium. I would argue as a clinician that disorders or differences of sex development, I'll come to nomenclature in a second, is a real paradigm for the management of complex conditions. It affects about 1% of the population. It's congenital, treatable but not curable. It has a public health significance. We talked about fertility and cancer. There is a clear, pervasive challenge to quality of life, requires interdisciplinary care, and there are chronic conditions that require transition from pediatric to adult care. Now, it's a paradigm in the sense that I could have put here diabetes, short stature, any kind of autism, anything in the world of pediatrics, all this list would have applied. So I want to talk about a few uncertainties, and I'll mostly focus on the first few, the naming, the nomenclature, the diagnosis, gender, genital surgery, and disclosure. And I'll fit it all in less than half an hour. Labels are confusing. That's one of my favorite pictures when I go to the grocery store. Muscle milk contains no milk. And that's my transition to the 2006. In fact, it was in 2005 that it happened, but it was published in 2006. The consensus happened in Chicago. It was a multidisciplinary consensus that included a couple of individuals that had an intersex condition, and there is still considerable debate of whether they were representing a particular society or not, but I won't go into that. The consensus statement was published, and I want to focus about one of the outcomes of the consensus statement, which is the renaming of the word intersex into DSD for disorders of sex development. And the definition that came out of this consensus, and I have to admit, because there has been so much debate, but behind the scenes, or in fact not just behind the scenes, but in reality, I was the lead of the subgroup, the subcommittee that was discussing questions of nomenclature. So I played an important role in this, and I'm not hiding from it, in this nomenclature. And the decision, the consensus decision was to name DSDs as congenital conditions in which the development of chromosomal, gonadal, or anatomical sex is atypical. And I'll just briefly pause here to just say that, well, it may sound obvious, at least from a clinical perspective, to say, well, of course, it's just a little bit of everything, chromosome, gonads, anatomy, and it's atypical. And I'll just, because I know we had historians in the audience, come back to the fact that it's actually quite novel, and don't talk about the word disorder yet, but to just put together these various parameters as part of the definition was actually a very different step, a big step forward, in my opinion, from what had been done previously, which was since 1876, the nomenclature was based mostly or solely on the gonadal taxonomy and the gonadal tissue type. And it was the gonads that were defining sexes. And there are sort of famously 5 sexes. Male who have defined by the presence of testes, females defined by the presence of ovaries. But then there were 3 others. And so there was one that's the hermaphrodites, defined by the presence of both testes and ovaries. But then what's happening with the last 2? Well, of course, physicians were wondering, well, what's going on? There are some individuals who seem to have ambiguous genitalia. They appear ambiguous. So they look like hermaphrodites. However, inside their gonads is not hermaphroditic. It's not a combination of both testes and ovaries. So what's going on? Well, very simple answer to this is because we're so focused on the gonad. If they do have testes, they will be called male, and because they look like hermaphrodites but are not really true hermaphrodites, we're going to call them male pseudo-hermaphrodites, and that's the 4th sex. And the 5th one was the opposite, ovarian-bearing individuals who had ambiguous genitals, and they were called female pseudo-hermaphrodites. So this classification remained until 2006, where finally we could say, there is more than just one parameter to defining sex. And it's a more complex situation. There is not one single marker to say like, aha, you are a boy or a girl. It's a combination of things. Now, this change in nomenclature, especially with the word disorders of sex development, rapidly received a wide consensus from all clinical specialties, and it's supported by authors of major endocrinology, pediatrics, and neurology textbooks. If you look at PubMed, DSD has been widely accepted. Now, of course, as you know, there has been a lot of debate. There has been, and I'm just quoting a few things gleaned from literature, intersex, internet posting. I'm not a disorder. Words can wound. Why not variations of sex development or differences of sex development? People are free to identify as intersex, which is absolutely true. Now, I've argued a number of things that intersex, one of the reasons to sort of push aside from the clinical realm, not from the societal realm, because I think it's perfectly valid, was that intersex was a vague term. It was unclear whether one needed to have ambiguous genitalia to be intersex. In fact, there are, in the classification, women with complete androgen sensitivity syndrome were sort of happily or not, I don't know, but sort of folded in the intersex nomenclature without having any kind of external sexual ambiguity. Do men who are XX or women who are XY, so no ambiguity, qualify? What about transgender individuals identifying as intersex, which is common, but then of course from a clinical perspective it confuses a lot of the issues because really they're quite separate. DSD clearly includes conditions that do not necessarily appear with ambiguous genitalia. I'm sort of repeating myself. Intersex has a political meaning and a history. DSD does not. And I would say sort of the way I was seeing it at the time is that intersex could refer to a social identity and DSD to a medical diagnosis, kind of a simplistic way of looking at things. And as a diagnosis, and that was my impetus to change the nomenclature, the idea behind this for the betterment of the management of intersex condition was that finally knowledge from all medical fields apply. And I think Ellen used words to express that better than I, that it was not the unusual. It would be just like usual medical care. So, and that evidence-based medicine should be used for all medical and surgical decisions on patients with a DSD, which I thought was a good thing, not just individual surgeons just deciding from themselves out of the blue that they have the right to perform surgery if it's not evidence-based. So is that terminology, how does it fare? I'll just show you two papers. This one that concludes that there is a broad support for the new terminology by parents and health professionals. And it says in the conclusion, the description, disorder of sex development may be helpful to parents at the time when it is not possible to assign gender, after which etiologically based diagnosis should be used where possible. Meaning, if we know exactly what the condition is, we should just name this this way and not just disorder of sex development. Here is another recent paper that concludes that our results indicate that the majority of parents and patients with congenital adrenal hyperplasia are dissatisfied with the term DSD. So certainly opinions do vary. So it's really a world of uncertainty. As I learned, you could say, well, you should have known before, but it's, you live and learn. Medical labeling has a lot of clinical and social consequences. Should clinicians label members of a sexual minority? It's a real question. Should there be an intersex exception when it comes to clinical labeling? I certainly was not in favor of this because I think it undermines the idea that evidence-based medicine should apply, but we can discuss. And I am hoping that there could be some kind of a compromise, keeping the DSD label and have it applied differently as either disorders or differences in sex development. In terms of diagnosis, there is a lot of uncertainty. And I'll just, this is not a genetic lecture. I'll just tell you for 2 minutes the kind of things that we're doing in my laboratory. I'll give you 3 examples of conditions, XY gonadal-degenesis, XY testicular DSD, and XY ovotesticular DSD. And as you can see below, there is a large percentage of these conditions that have no known genetic etiology. We don't know why they happen. 70%, 10%, 90%, staggering for XY ovotesticular DSD, formerly known as true hermaphroditism. Why do we care about this? Well, I would argue that from a patient's perspective, and it's something I've lived throughout the years with families eager to understand what was going on, it is a shortcut to the so-called diagnostic odyssey that's often experienced by families. They come back and back and back, and they're always asking, what is going on? We don't understand. It provides genetic counseling, and it's an aid to reproductive options for the family. It's also an aid to monitoring, because often by providing a genetic diagnosis, we identify associated risks that have nothing to do with sex, but other developmental issues. And it's also a guide to the natural history of the condition, giving the families an idea of what is going to happen. And it has what I would call a cathartic effect. It provides a finality of the diagnosis, it explains the condition, and it really reduces the uncertainty, allowing the family to move forward. How do we reach a diagnostic in the modern era? Well, it's been, our field of genetics has been transformed by the genetic revolution, especially the technology of sequencing, for which the cost has decreased dramatically and the speed has increased dramatically. And if you think that in 2001, first sequencing of the human genome, the cost was about, to sequence one human genome, was somewhere between $1 and $3 billion, and it took about 10 years to complete. In my laboratory now, we can sequence a human genome in about 2 weeks for a cost of about $3,000. So it has changed our way to think about medicine. And that's sort of the cost here that goes down not following the Moore's law of what's typically happening in technology. And the kind of studies on a research base that we're doing to understand the genetics of intersex is to basically perform sequencing of individuals. This was a cohort of 40 individuals, XY with a DSD, and just to just go directly to the conclusion, we find a genetic diagnosis in about 50% of the cases, which is much better than before, but it's not 100%. And you know, we end up also understanding better the spectrum of the conditions. We had two patients, one with one testis on the side and the other with an ovotestis and fallopian tubes on the other, whereas the other one was a patient appearing completely female, but she was XY with lack of menstruation and lack of puberty. So two very different presentations, one a newborn with ambiguous genitalia, the other one an adolescent not menstruating. And yet when we do whole exome sequencing, when we sequence the entirety of the exome, we find the same, we find a mutation in a gene called MAPK1 with two different presentations. So what we've done here is expanding the phenotypic spectrum. So this is really using clinical next generation sequencing usually provides an unprecedented rate of diagnosis. There are many reasons why we are not at 100%. Environment, for instance, being one of them. Also our inability to interpret. There may be novel genes out there that we can't interpret. But so we need really more research. And I would be remiss not to mention that in any investigation of the genome, there is always an inherent ethical danger of discovering incidental findings that have nothing to do with what has been looked after. Example, genes or mutations for dementia or breast cancer and so forth. I'll now finish briefly with a few other uncertainties. One is about gender assignment, and you know, the various views I've tried to sort of put together as traditional view versus challenging view is in the traditional view that the gender identity determinant is the gender of rearing, sort of following John Money's footsteps, and the role of the genitalia is crucial to identity and adjustment to it. Whereas the challenging view is that it is biology that provides an important force behind gender determination, and prenatal androgen being one of them, and the role of the genitals merely reflects brain masculinization. So how do we assign gender? Well, of course, from a clinical perspective, you always look at the outcomes from the medical literature. You consider the various parameters, hormones, fertility, genetics. What about external genitalia? Should they count at all in gender assignment? I'll give you the example of CAH, or congenital adrenal hyperplasia, in which individuals who are XX end up having masculinized genitals because of an excess of androgens, which is a male hormone, during their fetal life. And their internal reproductive organs are female and fertile, but the typical assignment has always, mostly always, been female, mostly based on sort of the trump card, which is preserving female fertility. Now, what happens with gender? It's quite interesting. If now there has been enough time to actually figure out that, you know, what's really is going on eventually. The vast majority of CH that are very masculinized, so they are still reared as girls, no matter how masculinized they look. Sometimes they're mistaken for boys at birth, but when it's discovered, they often are then reassigned, including surgery, and reared as girls. Well, the vast majority, on an N of 250, 95% maintained a gender identity as women. You can say, well, that's all great, you know, that was the right thing to do, except that 5% experience serious gender dysphoria. I'm sorry, not dysphonia, dysphoria. and actually, interestingly, not related to the degree of genital virilization. So it didn't matter. You couldn't predict the gender dysphoria initially. You could say 5%, let's just forget about it, except of course 5% is a lot if you compare to the rate of gender dysphoria in the general population. Now, what's happening with rearing kids with CAH as boys? Well, that's interesting. And that's something I've wrapped my head around, and I have a tendency now to promote, and you're going to see why. In the initial study, those are small sample size, N of 35. And out of those 35, they were initially assigned males, but not reassigned females after the diagnosis. Now, only 18 out of those 35s were adults at the time of the study, so 4 out of those 18s had gender dysphoria. But in another series of an N of 10, there was 0 out of 10 as adults with gender dysphoria. So I would say the jury's out on this one. What about genital surgery? Well, of course, the traditional view is to say the anatomy must match the gender of rearing to reinforce gender identity and allow sexual intercourse in the chosen gender. Well, not chosen by the patient, mind you. The decision maker is the physician and the family, because it can be the child. The challenging view is that genital surgery is made for the comfort of others, but it has negative consequences in terms of difficulty to change gender, and of course, a lot of evidence now point out to difficulty to sexual function. The decision maker is the patient when old enough. So how is the decision making about genital surgery? Based on literature, there is little available with no easy objective assessment, and one of the mainstay of arguments from surgical groups is to say that surgical techniques change. So you can say, well, here is an outcome study, a retrospective study looking at outcomes, and that say, this doesn't work. And the surgeons would say, oh, yes, but a year later, we changed the technique. So therefore, you can conclude anything. So it's what I call, shifting the goalpost. It's just, you can never prove anything because, of course, the techniques change. So there is really no good evidence-based answer. It becomes an ethical question. And I would say, and I always, when I see patients in the clinic, ask, and many parents are eager to perform genital surgery. And I've also often wondered why they were so eager. We can talk about it maybe later. But I always ask, so ask yourself these questions. Would anyone desire atypical genitals? And if the answer is so obvious that it's no, maybe you should think twice, because it's, there is certainly zero evidence for that. Will surgery create normal-looking genitals? Will it preserve sexual sensation? Will there be complications? And surgeons are sort of almost wired to be optimists. They always say no. And will surgery solve psychological issues? And of course, surgery is no good replacement for mental health. So what's happening with surgery and CAH? Well, if they're reared as girls, of course there is always a genital surgery, often, as we discovered, multiple surgeries, and as we now know, multiple complications. Vaginal stenosis, which is a narrowing of the vagina, hairy vagina, short vagina. The results in terms of function and cosmetics are not optimal, leading to pain during intercourse, cosmetic dissatisfaction. What about if you rear the CAH patients as boys? Well, this one's easy. There is either no surgery or maybe a simple surgery for hypospadias, but the surgery certainly do not touch the tissue. So there's no loss of sensitive tissue. The disclosure, of course, the traditional view is to limit disclosure to prevent gender identity confusion. The challenging view is full disclosure to prevent secrecy and shame, which, as I've learned throughout the years and my multiple discussions with advocates, is really a major part of discomfort. So I'll finish by talking for a couple minutes about what my recent sort of figure or role has been in this. And there was an article in Nature a few months ago depicting me deep in thoughts and just, having a storm in my head. And it's entitled Stuck in the Middle. And Eric Vilain built a career studying aspects of sex that make some people uncomfortable. Now things are getting uncomfortable for him. Ton, ton, ton. And I'll give you two quotes from this. A quote from Arlene Barrett, who is a well-known intersex advocate, in this case speaking against genital photography for diagnosis. We live in a community of people who have experienced the harms of these practices. And a quote from my colleague David Sandberg, who's a psychologist at University of Michigan, who says, "I never question people's experiences. What I do question is whether they're generalizable." And that's often a conflict in the, when clinicians discuss with patients' advocacy groups. I would say in the 90s, there was a lot of these conflicts between the advocacy group and the medical community. And there are well-known pictures of hermaphrodites with attitudes, so which was the logo or the of Intersex Society of North America. And here you see Beau Laurent, at the time Cheryl Chase, discussing with various groups depicted in this article from the New York Times. Then there was the consensus where, for the first time, everyone seemed a little happy. Everyone was at the same table, so we thought, well, maybe the frictions are going to go away, and maybe a possible moderate, long-term approach, consensual approach for care of intersex children. To sort of enact on the consensus statement, in 2011, the DSD Translational Research Network was created, and to sort of respond to what was needed, the gaps in research, and this is a network of now 12 clinical sites. I'm one of the two PIs with David Sandberg at University of Michigan, and the executive coordinator is Dr. Delott, who's in the audience. And again, and in the middle, there is a Court Alliance, which is has been trying to be a conduit between the clinical sites and the advocacy groups. So the idea was that maybe there was a unified progression of the medical community and advocacy groups to further DSD research. So we were all singing Kumbaya, but then things sort of like came, took a slightly different turn, and everything was still brewing, but there were two events. One was the beginning of a different strategy from some advocacy groups, and this is probably the one famous, still ongoing lawsuit of MC, which is this little kid here in the picture, versus Aronson, who is a famous pediatric urology at Medical University of Southern Carolina, not California. And there is a lawsuit against this surgeon and against social services for having performed genital surgery, feminizing surgery. The lawsuit was both federal and state. The federal was dropped, but with no evidence of infringements of civil rights. But there is still a state lawsuit pending, which would be, it's going to be a very interesting outcome. There has been a number of resignations from our DSD Translational Research Network, from the advocacy groups that we had convened, the AAN, the advocacy network that we wanted to interact with, and there was a sort of an op-ed, if you will, from Alice Dreger entitled "Rejecting the Tranquilizing Drug of Gradualism in Intersex Care," and she resigned, saying, "We seem to be hitting a major impasse, one I feel caught in," basically suggesting that the clinicians are not listening to anything and it's going nowhere. And this was the letter from the advocacy members, statement of resignation of some AAN members from the Translational Research Network. We are extremely disappointed that the Translational Research Network has not lived up to its initial promise, which I don't, the promise was improvement of care. and I think I would argue that the jury's still out if it's lived up or not to initial promise. This is a quote from Eric Vilain in response to Dreger, in his mind only, because I decided to drop the matter, but that gradualism does not mean immobilism, and progress is actually happening. And progress is, of course, slow, and it's slowed down because it has to be measurable, then translated to the bedside. So yes, it was slow. And I'll finish with this just a sort of additional debate of whether intersex surgery are a human rights violation or not, with basically a number of bioethicists and a number of public groups calling intersex surgeries torture. And I'll leave you with those two quotes, one from Alice Dreger, who is a famous historian of medicine and intersex patient advocate. These are social interventions on your genitals. If we're going to use that language about Africa, we're going to have to use it here. And myself, trying to be stuck in the middle, this completely antagonizes the medical community. This is not progress, in my opinion. So what's next, I don't know, but I have the feeling that it's sort of going a little full circle in terms at least of difficult dialogue with the clinicians. Thank you. Yes, sure.
I'm pretty loud. I don't usually need a microphone. So, taking from the title of today's entire seminar, what do we want to call this, symposium, going beyond the binary, right? So I'm interested because one of the things you mentioned, which I thought was very astute, was that even though DSD has no history and no social context and no nomenclature, you did notice eventually that clinically naming things does have societal impact. You later go on in your speech and your talk that was very interesting to be talking about gender assignment. And this gender assignment adheres strictly to binary. And so I'm wondering whether in the attempt to go beyond the binary, we have to rely on our clinicians to reinforce this in parents that this binary is not something that needs to be adhered to.
I think that what you're talking about is sort of bringing up the possibility of either not assigning any gender or opening up to other gender, pan-gender, and yeah, embracing one of the 54 Facebook possible genders that are possible. No, I'm following you. So and by the way, historically, that has never has been a sort of a demand from the intersex advocates. I mean, if you were, it's there. This was for, and I think I should let Georgianne talk more than me about this, but it's just, so this is certainly, I think, it's a relatively novel phenomenon. Again, I'm a scientist, and I think these kinds of things should be totally proposed. It is, you're right, gender assignment is completely binary. There is certainly no discussions in the clinic to say, hey, we can withhold. Now, I can tell you one anecdote of, and that's a problem, they're only anecdotes, is I do have a family with 2 children with CH, and the parents have decided to not assign any gender. And which was new, and it's a family from southern Mexico. They actually don't have, they've never heard of intersex, they've never heard of gender. They just, they speak some English. So, and we just said, sure. The demand came from them. Interestingly, now one kid is 5, the other one's 3. The 5-year-old looks completely like a boy. The 3-year-old looks completely like a girl. And I said to the parents every time they come, it's like, well, why is one in pink, the other one in blue? You told me that you would not assign a gender. And they say, oh, we didn't. They picked it themselves. I was like, oh, that's very interesting, because they have both the exact same condition, the exact same mutation. They're both XX with CH. And voila, so it's sort of like a reverse of the John Jones case here. But it's something I would say that in the clinic comes from the patient so far. Should it be part of one of the options on the menu? Absolutely. Yep.
Yeah, I'd like to just follow on from the last comment. This is absolutely fascinating for me. I'm a historian, and I'm not a historian of medicine. So,
For people in the back, they can hear you.
yeah, can everyone hear me? Doesn't sound like it's not.
You're right.
So I can talk loudly if I need to. And if you capture if I speak up or not.
Yeah, maybe if you stand up. Yeah. Yeah.
Okay, so I am not in the medical field. I'm a historian. I'm not a historian of medicine. I'm a social historian of Africa. So but I am also very interested in and somewhat knowledgeable about issues of gender. So I really would like to follow on from the last comment, which is I think that when we use terms such as normalizing, such as, and again, I'm speaking from somewhat level of ignorance, disorders, what we're doing is we're pathologizing a condition that may not be pathological, right? I don't know what kinds of cancers may develop from an intersex condition, but I would think that if that does occur, we can say this is an individual that has cancer of X, and a relevant factor is that this is an intersex individual, right? So we're taking a condition that has developed and saying that's the issue, and here's something that might be relevant in helping us understand where it came from, how to treat it. I think that if we start looking at gender as something more than a binary identity, and look at it as a range of identities, then these issues start to, in a way, solve themselves. We're not imposing word, that's a loaded term. We're not using normalizing surgeries because there's no norm, right? Intersex becomes a variation of sexual development, and I think that at that point we can move forward and ask what's the best for this particular child, right, or this particular adult or adolescent. So I guess this is just a plea for us to move beyond the binary and start to be really careful about terms such as normal, disorder, and maybe use variation or difference, which is not as loaded. Does that make sense?
Well, it does make sense, and the reason why the word disorder comes up is because patients, families, they do come to see a doctor, you know. So why would intersex be different from people coming with a disorder of heart development or a disorder of face development? And here there is no issue, or cancer, we don't say cancer is a variation of the life of a cell. It is a disease, and we, you know, so so the issue here is, I understand all what you're saying, but the reason behind the word disorder in this historical context was to actually bring the doctors to not make rash decisions, but say, hey, let's do evidence-based medicine for these families who are in distress. So I think we're past that. It was a historical step, and I'm perfectly fine with sort of, you know, retreating from the word disorders, because maybe the goal of now having a lot of clinicians think about, oh, we really need multidisciplinary care, we really need to have evidence to provide surgery, has been accomplished. And then, yes, we're past that, but I just want to put things into context. This was certainly not intended to say, to have a stigmatizing effect, which it might have had, but you know, it's you know, realpolitik. Yeah.
Oh, great. This is working.
That's working.
So I'll ask this time anyway. I have two questions. The first question is, it seems like in the past, intersex was used to describe people who have lost their genitals due to accident or injury. The new term DSD does not include those people. It's only people with a congenital condition. Is that correct?
Well, the second part is correct, but the first part, I don't know. I don't think that intersex was historically a term for people who had lost their genitals. I don't think that's correct.
I was thinking of the case that...
The John Jones case.
Yeah.
But that's, I don't think everyone ever labeled David Reimer as intersex. Yeah.
And then my second question was, right now, when clinicians go out and talk to patients and their parents about intersex conditions, do they have a set of advice that they give parents, or a set of treatment, or is that still something that's being developed?
Well, so that's certainly one of the goals of large clinical networks, to develop those guidelines. But there, of course, there are a number of documents and a number of readings that are provided in all big centers throughout America, which really shows the importance of having teams with different opinions from the doctors, and also have I would say correspondence that come from the advocacy community. However sometimes contentious that could be, I know that in our practice here we always provide multiple names of intersex advocates to our patients. So yes, absolutely. In modern practice, it's unconscionable not to provide all these documentations, and they do exist. But they do exist. They could be much better. But there's still, there's still a number of better evidence to be had. Yeah, you wanted to follow up?
So then let me just follow up and ask you then, what kinds of guidelines are you giving
What?
patients right now?
Well, it's
The list of
no. I mean, this is not. This is a dialogue. This is not. Here's the advice. What you should do. This is a lot of these advice are lifestyle choices. So they're and most pediatric medicine, I would say 95% of pediatric medicine has become sort of a dialogue with patients, except when the kid is bleeding in the ER, then we know what to do, stop the bleeding. But the rest, whether to provide growth hormone to short kids or what kind of treatment for autism, is just, all this is certainly a dialogue with the families, and they have different views.
I was very interested in the fact that these children become patients because their parents bring them into the clinic.
Right.
So in a sense, one could say it's the parents who have made a diagnosis in the sense that something's wrong. And I wondered, in the literature, are there any cases where a person, intersex person, was not treated or not brought to a clinic, and then came on their own later for medical advice with problems later in their life, but they had not had any kind of medical intervention earlier.
Yeah, that's a good point. But there are sort of two peaks of frequency in the world of clinical intersex. There's a newborn where indeed, the patient sort of declare that's a patient, but there is a later onset at adolescence where we've seen in the clinic some patients as adult coming on their own and saying, I do feel different, or I don't menstruate, or I want to have babies, or so there is it's not just patients. It's a combination. You done? Thank you. Oh.
My question was with regards to pedagogy.
In regard to what?
Pedagogy. You mentioned bringing this information to the bedside, and I'm also wondering about bringing it to the classroom. I've gender sexuality studies. I've had a number of students over the years talk about a desire to go into medical school or transitioning and struggling with some of the material, feeling that gender studies they were struggling with finding that in the material. And I'm not certain if that is if that's place-based.
No, I mean,
you come here from a red state.
right. you're preaching to at least my choir, and I think the choir of a lot of people, you're singing my song. I mean, education for medical students on issues of intersex, transgender health is completely underrepresented in the curriculum. It started, I would say only 5 years ago for transgender health, and I was asked to talk about to be, I was asked to create this curriculum there, and for intersex a little earlier. But here, because I'm here, it's a little easier. But there has been studies looking at curriculums of all the medical schools in the U.S., and it's completely underrepresented. Absolutely, it's those are a general physician is meant to encounter individuals who are either trans or intersex in their practice. That's for sure, and they shouldn't add to the stigma. So I agree with you. It's not done.
Thank you very much. And now I think we can have some coffee, tea, and